So we're going to get going then. So I'm Judith Franz. I'm the Vice President of Client Services for VITL, and my team and I are the team that are responsible for rolling out the VITLAccess service across the state to all different kinds of healthcare organizations. We've been doing it for about a year and a half. We're very excited about it, and we are gaining lots of traction now. We have some new automation features in the service itself that is really exciting, that we're beginning to incorporate into the rollout with a couple of clients coming up. And we are up over 2,200 users and expect to have about 3,000 or so very shortly. You're looking confused. Do you need help over there? No? You're good? Another microphone? Okay. I don't know if you have
Just, there it is. Okay.
Chris has them.
No, it's fine.
Okay, so we have just a few slides here to go through just to introduce ourselves, our client panel, and VITLAccess, a VITLAccess and consulting engagement that we recently conducted, and then we're just going to kick it right off into a discussion, okay? To my left is Andrea de la Briere. She's a senior solution consultant on my team. She's been with VITL for about
8 months?
8. I was going to say 6. Okay, so 8 months already, and has been very involved with the rollout of VITLAccess and communicating the value of the service to our clients. I think I have to be over here, don't I? I don't have a clicker. Not knowing which one was, can I do it down there? Yes. Okay, so we have 3 client panel members with us today, and Colleen, you're going to have to pronounce your last name so I don't. Kohaut.
Yeah.
Okay. She is a resident service director and owner of Franklin County Rehab, along with 2 other organizations, 2 other centers, the Villa Rehab Center and the Holiday House, both in St. Albans. Is that right?
Yeah, that's right.
And the Franklin County Rehab Facility is a 5-star, 64-bed skilled nursing facility also in St. Albans. They're very proud of that 5-star rating, and they are a 6-time winner of Vermont's Gold Star Employer Award. Please welcome Colleen. Our second client panel member is Lauri Snetsinger. Got that one. She's a registered nurse and the clinical nurse manager for one of the FQHCs, the Health Center in Plainfield. And their motto is healthcare the way it ought to be. They offer not only primary care services, pharmacy, dental, and behavioral health. And of note is the fact that the health center was one of our pilot sites, seems like a long time ago, almost 2 years ago, when we first were experimenting with onboarding VITLAccess across our client base. They stepped up as the FQHC client segment representative and really helped us figure it out back in the early days. So we have a third member of the client panel, Dr. Kathleen Knight, and I'm going to let her introduce herself. She was very busy and wasn't sure if she was going to be able to make the time that we had the session slotted for, so we're very happy that she's able to be with us here today as she is a VITLAccess user. So you introduce yourself, Kathleen.
I have a primary care practice in Lyndonville, Vermont, and I do alternative medicine primarily, and I've been using VITLAccess for almost a year, or a little over a year actually.
Awesome. Great, thank you. Okay, so as I mentioned, the health center, so everyone has a different sort of history with onboarding VITLAccess and using the service. As I mentioned, the health center participated in our original pilot, which was almost 2 years ago, and they were very successful in collecting patient consent, which is a big piece of this. And since then, participated with us in a VITLAccess consulting engagement, which I'll speak about a little bit further in a minute. where Franklin County Rehab Center did not have the history of participating in the pilot, but they were a participant in the VITLAccess consulting engagement as well, and kicked off the onboarding of the onboarding of the service just recently, starting with the Franklin County Rehab site first, and then with plans to roll it out to the Holiday House and the Villa. And as Dr. Knight just mentioned, she onboarded about a year ago and has been using the VITLAccess service for about a year. So I think this is the last slide. So what we did was we partnered with our infrastructure vendor, Medicity's professional services group, to a group of consultants to help us improve the way that we introduce VITLAccess to our client base and the way that we sell the value to clients. So think for a moment of all the different kinds of clients there are that we serve across the state of Vermont. Think about an ED doc in an ED setting, or a nurse or physician in an FQHC setting, or clinical providers in a nursing home or an independent primary care doc. And think about the different those different settings and the different type of care that they are trying to provide at that setting. So it's sort of logical to think that the information that they may need at any given time in any of those different settings may be different across the board. So if you're an ED doc and there's a patient coming through the doors and they're being brought in for you to see, this more than likely is a patient who you don't have a relationship with, you've never met before, you don't know their history, you don't know their allergies, you don't know if they're on medications, you don't know if they have chronic conditions, you really don't know anything about this patient except for what you're seeing as the presenting issues at the moment. So the use of VITLAccess in that situation may be very different than one in the usage of it in an FQHC. So what we did was we engaged with the Medicity consultants to help us build value statements or use case scenarios across our major client segments. We had 6 client participants in this engagement, and they were the Health Center, Franklin County Rehab Center, NCSS, which is a Northern Counseling Support Services, Rainbow Pediatrics, and NMC and SVMC representing the hospital segment. At the end of that, we developed about 25 use case scenarios or value props to enable clients to understand how to incorporate the use of VITLAccess into their workflows better, and also help my team understand and sell the value prop to all these different types of clients across the board. Okay, so with that, we're going to roll right into starting to walk through both the idea of the global patient consent and how we incorporate that into our onboarding process, and then the use of the service itself. We have some questions that we're going to pose to our panel, and then we're going to invite you as audience members to ask questions in response to what they're sharing with us, and then we will open it up at the end to a full question and answer. So please don't be shy. As we pose these questions and our panel members start responding, if you have a follow-up question or you want to learn a little bit more about what they've just said, then please just raise your hand and we'll get a mic to you and entertain those questions. So, Andrea.
All right. Thanks, Judith. So I have a warm-up question because I actually think it's really important to get to know people that are answering other questions for us. I'm 99.9% sure you'll know the answer. So can you share with us what your first concert experience was?
Goodness gracious.
Come on, Lauri.
Let's see. I saw the Police in Montreal in 19 1980.
Excellent.
She's giving the
Excellent.
year too. You're very
I knew
brave.
you'd know the answer.
She's very brave.
I think my parents took us to Johnny Cash and to June Carter at the Flynn Theater, and I don't know, I was young, so
You
I'm
came
not
to
gonna
the
tell the age.
Flynn? I'm so envious.
Yes, years ago.
That's great. Dr. Knights?
I can't believe I'm going to say this, but the Pink Floyd in New York City, and I can't remember.
Excellent.
Not surprising.
It was a really good night.
That's awesome.
Excellent. So our first question related to business is, when even the most sophisticated organizations have barriers when they're trying to adopt something new, and in this case, implementation and adoption of VITLAccess, can you identify, this is for the whole panel, can you identify one key element, whether it's consent collection, awareness of the site, the value proposition, whether that, what's in it for me, basically at the end of the day, where that became a challenge for you to implement the service? And in no particular order, feel free to jump in.
Well, I was just going to say that one of the little bit of pushback from the providers was the fact that they had to sign on to something else. They, had to sign into so many different things, and so that was one of the things that they were a little bit not excited about. So, yeah, so we had to kind of build our workflow around that.
Yep.
I would say probably the same thing. We had just put in an electronic health record for the building in kind of the mid-2014. And then we're connected with Northwestern Medical Center, which is located kind of right across the street, and then obviously with UVM Medical Center. So we have a lot of different computer systems that we're trying to access. So having one more, I think was the barrier. As Andrea said, we just started in June, but I think there's a lot of value there, but I would say that it was trying to convince staff that there is some value, and it's not just another system to sign on, another username and password kind of a thing.
Mhm.
So
Thank you. Yep.
Well, I am the staff, so I've enjoyed implementing it. It's part of my workflow. Every new patient that comes in gets a consent form. Initially, I tried to have the consent form on my EMR, and it wasn't able to print out. So when the audit came, I was a little stressed, but thankfully the audit was just when I first started, so I only had a few patients on there. So that has helped me. It's just more paperwork though, and more scanning and putting it in. But I have enjoyed using it because the nature of what I do is I dig into the past and trying to see what's been done and what hasn't been done, and trying to get to the root problem. So it's been very useful for me.
Good. When you were talking about printing earlier, was that out of the VITLAccess service, or was that not being able to print?
Oh, no, it's through my
Through your
health, my
Okay.
you know what I mean, the EMR.
Gotcha.
I would like to have it just in there so that when they do the consent online, because I have the health history questionnaire and the consent forms are on there, and it automatically checks a box when I'm checking them in so that I know that they did it. But it's an extra step right now, but it would be nice if they could be integrated into the EMR that way.
Mm-hmm.
So can I just jump in here with a
Absolutely.
follow-up question? It's for any of you, but I was just thinking about it with Dr. Knight's response. So you just said, I think, that you, as part of your workflow, and you ask every patient, who comes in, you engage them in the conversation about the global patient consent and ask if they'd like to sign the consent.
Mm.
So from your perspective, was that hard to do? Was it a hard conversation in the beginning? How much time does it take you to do that? And what was your patient's, overall?
Well, I have the
general
pamphlet right there. So I hand that to them if they want further, but I basically explain to them that it's a way to see what they've had done at other providers' offices so that we don't have to wait for it to be faxed. And, or mailed or whatever, it gives us immediate access, but then it also quickens the ability to see their results when I send them in for labs. And they're usually, that's enough. There are some people that are hesitant because they feel like everything's being exposed on the internet. And that is one area that those people, I think, would like to have consent, and then they would like to default from that consent at the end of the visit and would like to redo it every time. And I don't think VITL is exactly set up for that. I think I've had 3 patients want to do that. So I think it would be, I don't know how that works on a technological end, but for some people they feel comforted in the sense that, yeah, I'll give you access and then I can withdraw it at any time.
Thank you. Any other questions before we move on to the next one?
So, do you check in the system before to see if they want to get consent before?
Mm-mm.
Consent, or do you normally ask for consent?
I give it to everybody.
Oh, okay.
And then if I go in and it's already, I don't have to opt them in because they're already in.
Oh, okay.
But I would say a majority of my patients have not been opted in.
Right. Yep.
So, I'm Richard Tino. I'm a doctor in Burlington. So if I were a patient signing that, I would ask, do I have access? And my second question is, how many do I? And then
Yes,
number
yes, you
2,
do.
how many people have asked? How many patients have asked when they sign that form, do they have access and use it?
Yeah, so I can take that one. So it's a provider portal, so it's for treating providers only, and it's a global patient consent policy. So it's a provider portal for a treating provider only. So you're in a treating relationship with the patient, and it's not a patient portal. But having said that, the patient has a right to request an audit, so to speak, of every provider who has accessed their information, and also what information is about them is resident in the VHI. So if I wanted to know what kind of information is stored within the VHI, the Vermont Health Information Exchange, I could request that and make the request of us, either through my physician or directly with VITL. And we could tell that person confidentially what kinds of information is in there. So there's demographic information, there's clinical information from these contributing healthcare organizations who have treated you, Judith, in the past. And, you know, we have lab results, and, you know, we have radiology results and the like. And then who has accessed that information. So I could see and verify that, you know, my primary care doc, you know, looked at my record, and my OBGYN and my dentist, and, you know, folks who should be looking at my data. So they have that opportunity. Yep.
So the patient can look at the primary data?
No, providers only.
In this?
Yes.
But as I'm signing up for,
Yep.
basically anyone can look at my data?
So, yeah, it's a global,
I'm asking,
yep.
I'm trying to understand. Can I say that I want access to data as well?
No. So it's not a patient portal, it's only,
Can you get the same access that you just signed off on yourself? So,
can you get the same access?
yeah,
Somewhere
so I'm
else?
signing something that
Yep.
says anyone can look at this
Yep.
data set.
Any treating provider, yes.
Treating providers.
Yes.
I'm asking, how do I look at that exact data set?
Yes, so you don't look at that same exact data set, except that, I mean, you could, you,
medical online, the my
Yeah.
my health.
so
Portal.
independent providers can give you access, you know, to their data set that they have through their electronic. So UVM MC, for example, or your independent practitioner, but to see all of that data aggregated, you know, like it is within the VHI, you don't have that same view, except that you can make the request to ask what kinds of data.
I have signed that someone else, maybe the person signing with some other people can't.
Treating providers can, yes, yes. Yeah, and it's global patient consent. And so that's important to note that So if I go to see my primary care doc and he or she asked if I would be willing to sign a consent so that he or she could treat me better, having access to all the information that's resident in the VHI from across the state. And I say, yes, that makes sense to me. I'd like you to be more well-informed. I'd like you to know, see the x-ray from when I broke my ankle and I was treated down in Rutland, see my other records from the other contributing providers, because I want you to have the most information you can as my treating provider, so I sign off. It's called opting in. So I'm opting in and I'm signing. And we mentioned before, if I change my mind tomorrow or a week down the road or a year down the road, at any participating organization, I can opt out. So I can, in effect, change my mind and say, I don't want to share that data anymore. I'm not feeling good about it. And I sign a revocation form and I'm changed to opt out. And so think about it, now my data's covered up and no one will see it. And it is a global patient consent policy. So if I'm seeing my primary care doc today and I say, yes, I want you to be well informed, I want you to have access to view my data, it's view only, then I'm also granting permission forward. So any treating provider next week, next month, 6 months, a year, who's treating me will have access because they'll see that I've globally opted in. So if I'm seeing my primary care doc who I have a relationship with, I want you to see the data, and then I don't see anybody. 6 months later, I break my ankle, so then the ED doc up at UVMMC is going to be able to see my data if he or she would like to. And so it is important to note it's a global consent, so that we're sharing that data across the community so that any and all treating providers can help, with that care. Yeah.
I have a quick question. Oh, I'm sorry. What category of provider is access limited to? I'm thinking, as we continue to think about social determinants, and so community providers, also community health team folks that may not be a nurse, doctor, clinical. What does that look like?
Are in luck because VITL's CTO is sitting right here, so I'm going to start answering the question and I'm going to let him pick it up, because this has been a hot topic and a topic of conversation over the last few months. So it's role restricted access. So if we're working with a particular organization and we're talking about who on your staff do you think should have access to the data, and so there's demographic role-based access. So it could be a front desk person or it could be a nurse mid-level who's collecting the patient consent, and they have a demographic access only. So they have no need to see the clinical data. They're just going in, searching for the patient, finding the patient and saying, Judith has signed the consent form, so I'm opting her in and getting her all set up. But I don't need then to view clinical data because I'm not a treating clinician. But for treating clinicians, they would say, yes, we have, these 5 nurses or these, 2 mid-levels and 2 docs. We want them all to have access. We set them up with clinical access, and then they're able to view that data. And so that's for our traditional healthcare organizations. So I think independent physician practices, hospital-owned practices, hospitals, FQHCs, and the like. But we have recently started to receive requests from others. Think about a nutritionist, or think about others, the AAAs who are part of the overall care team for folks and are interested in having access to their data so that they can understand their whole health picture, and would like, to be able to view the data. But there are currently restrictions around which healthcare organizations we as VITL can grant the use of VITLAccess to. So here's where I'm handing over the microphone. I'm going to let Michael kind of fill you in on that piece of it.
Thank you. Along with being CTO, I'm also the security officer. This is a growing issue and one we want to address, but right now it's healthcare organizations and employees of those healthcare organizations, or healthcare providers, registered nurses, physicians, and such. It's limited to access by those organizations and or those providers. So that means folks like, for example, SASH right now today would not be able to gain access to that information. Now, there is an increasing need to expand the community of information and the community of care we provide, and so we have to think about how to do that, but it's not available today. Community health team, because the organization is kind of, you know, that primary care doc has granted access to them. That's right, yep. And just to get back to your question for a moment, what we do is totally consistent with what a healthcare organization would do with their own electronic health record, meaning that they would never give a user, a patient, direct access into their electronic health record, but they'd give them full access to all the data that's in there. So if you want to get a flash drive or a CD or something, and we do exactly the same thing. We won't make you a user of the system, so you can't access it using the application, but you can get a complete copy of all the information. Yes. Yeah, you can get a complete copy of all the information that we have on you. Yeah. Yeah, same thing as any electronic health record or healthcare organizations allow to.
Okay, so we're just going to, right, I'm
You
sorry.
You
No,
actually
I
hit
already-
on my question. I was actually just wondering if there was a timetable on when you're looking at more of the social determinants
Oh.
of health providers potentially having access.
Is there a timetable?
Not yet. We think it's really useful. We think it's a really useful thing for folks to gain access to. It's going to take our entire community of organizations who contribute information to us to kind of come around to that agreement, or the state to say this is an allowed thing. I mean, it's not it's a limitation that's put on us, right? We're not trying to limit it or even think it's the wrong thing to do. We think it's actually a really important thing to do, but it just, I don't have the timetable just yet.
It's not our decision alone, yeah. So we're going to take one more question, and then we're going to flip back to the panel for a minute to ask a couple more general questions, and then we'll keep the conversation going. So go ahead with your question.
Yes, I'm Andrea Hazuda, and I work in IT at Central Vermont Medical Center. And I have a lot of questions and concerns. As the person who runs PHI audits and looks at who's looking at whose record, I scrutinize that monthly. And I guess what I am hearing, and maybe I'm not understanding this correctly, is I'm a patient, I walk into my doctor's office says, hey, we're part of VITL. Do you want to sign up? And I say, sure, and I go ahead and sign up. Now I have this check mark next to my name, and any provider anywhere who has access to VITL now can look at my record, technically per my consent if I'm standing in front of them or go to their office, but I now have this red or green check mark that says, open book, go for it.
Yep, so I wouldn't put it quite that way. So they still have to operate under HIPAA. You know, they take the oath. We have security and audits in place. And I'm feeling like you're going down they're surfing around and looking at people's data, they will be caught, most likely, and they will be fired. So, you know, they need to follow their own organization's guidelines. They need to follow, you know, the security. We do routine audits, and any patient or any time we do random audits so we can see if the patient access is appropriate. There's a local security officer at every organization, and we have ongoing conversations. It's a person dedicated to this on Michael's staff, and Michael also does audits himself. So I'm just going to take a step back. So for 20 years, I worked for national EHR companies. That same sort of policy and security and restrictions exist for those folks. So back in the day when I worked for IDX or GE, or when I worked for Athena Health, think about it from this perspective. I had many clients who are national clients. I had access to their systems, and I then had access, you know, to their patients. I would never dream of accessing any patient directly or looking at data that I didn't need to do my job, or that they did not, you know, request me to do. There's all kinds of security and all kinds of policies around that, and I can tell you, if I ever had, I am 100% sure they would have discovered it and I would have been out the door. So it's the same thing if you go back to paper records, you know, you have, you know, the rogue employee who decides they're going to look through paper files. You know, it's the same sort of thing. And I would say that from my perspective, that is a more dangerous situation than it is to be working, you know, in the electronic world, because we have all kinds of safeguards built in that you don't have with someone rifling through the drawer. I don't know if you want to add anything or no. Okay, so we're going to put it back. Andrea's going to ask, go ahead, Kathleen, did you have a comment? Yeah.
I did want to bring up an issue that has occurred for me several times with VITL in that, and I hope it's not going on a bunny trail, but if someone went to a specialist that I referred them to, and they ran a bunch of work, and they hadn't met back with that specialist, then they come to me, and I'm looking at the data right in front of my face. It's put me in a very uncomfortable position as to who shares this data, which I refer back to the ordering physician. But I don't think there's anything in VITL that sort of honors that I know of. Maybe there is, and I just haven't been educated about it. But so that is a little bit difficult, I think, when you're sharing all this pooled data. And let's say I order a CBC, and for some reason they go somewhere else for their ankle, and then they view the CBC and give the results to the patient. That can get a little bit tricky.
Right, where someone else may share that with the patient before you have a
Right.
chance to do that.
And
Yeah,
vice
I get-
versa.
Yeah,
important.
So I
Yeah.
haven't, I've always referred back, but it's kind of hard. You know, I'll follow up with the patient and make sure that they're following up if I see something that's red flagged. But I think it's
Yeah.
going to become more real the more practitioners are doing
yeah,
it.
sort of a practical issue. So do we want to move
Thanks for
on
the
to our,
Yeah, so back to
Next.
the show.
yeah. Back to the
And
show.
so the next question really is probably more pertinent for Dr. Knights and Lauri, but Colleen, feel free to jump in if you have some experiences to offer. So an important part of the piece of the puzzle is when you're trying to implement a service like VITLAccess, can you identify the appropriate times to have the consent collection discussion with your patient, and also identify those staff members involved and who would be responsible? I know, Dr. Knights, you are the staff, but
Not for a long
you know,
time,
how that
but-
works.
Yeah,
in
so
your
what we're
organizations.
trying to get at here, this is really important because it looks different across different organizations. And so it would be helpful, I think, for everyone in the audience if you can talk about who on your staff collects the consent from the patient and when that conversation takes place. And since we've been talking about this a lot, we can probably move through this pretty quickly.
Well, for us, it started with the front desk, they were gonna do it, and then patients they're just overwhelmed by paperwork every time they come in, so we moved it back to the nurses. But it was also a good thing because, you know, people had a lot of questions, like, you know, the privacy and all that, so they were able to spend more time answering their questions. So we try to have the nurses do have people, you know, review the consent and then have questions or whatever, answer their questions, and then.
And did you have aides that you used? So it happened with the nurse after the patient's been roomed, as you put it at the health
Right.
center.
Yep.
Did you have any aides to help in that conversation between the nurse and the patient?
You mean like, well, we had the pamphlet and, you know, we had pamphlets in all the rooms so people could just look at them without us in there, and then they could also, you know, ask questions, specific questions. So, and then VITL gave us some scripts so we could, you know, we knew sort of how to answer the questions.
How long do you think it takes you to have that conversation?
Well, it depends on the patient. Sometimes it's really quick, and sometimes people just, you know, they just sign it. They don't read it. They don't, you know, they just sign it and that's it. Some people have, you know, a couple of questions and then they're good with it. I mean, really, well, when we were doing the pilot, we got 5,000 consents signed, and I think we had like maybe 2 or 3 that refused. So, you know, it was very minimal. So.
Thank you.
For us, we have a social work department that would go in, they check consent. If it's already been done, we don't need to do it because they may be coming out of one of the hospitals or in a primary care office, and they've already collected that consent. So we wouldn't have to do that, but it would be part of the admission process. We haven't done a ton of those yet, but we do check to see if they have them.
Thank you.
So it's a fun fact to share. Since we've started rolling out VITLAccess, our patient consent rate is 96%, and that has stayed really rock solid. It's only gone up to about 96.2 or something and dropped down to 95.7 or so, but this is a metric that I need to track on a monthly basis. And it's also, so that means only 4% of the population is saying no when asked. And it's also important to note that it's in keeping with the national standards. So across the whole U.S., for states that have the same, not every state has opt-in. Everyone is opted in, and then you can say I'm out. So you're in unless you say you're out. Here it's everyone starts in a default opt-out, and then once you have the conversation with the patient, they opt in. But anyway, it's in keeping with the national average for a 96% opt-in rate.
Dr. Knights, would you like to share any?
I think
We've
it's
already
been
shared.
going smoothly for me.
Excellent.
I do have something else I'd like to bring up, but I can wait until you open that up.
We're moving off consent, I think, but
Right.
is it related to
Well,
consent or is it?
yes, when
Oh.
giving consent, it would
Yep.
be nice, occasionally people have the same names, and it would be nice if you had to enter a date of birth in so that you're not accidentally picking someone else because you're rushing or you're trying to do whatever. So if there's just a way to enter in their date of birth so that you know you're catching the right person. I've been amazed at similar names, even the same year they were born. I mean, it's
scary.
Yeah, so I can give you tips for that, but you can enter that when you're searching for them so that they're pulled up that way initially, and then that limits, the records that would show. So if there are two Judith Franzes and you have my date of birth and you enter that in the initial search, then only one will pop up and not the one that's, 10 years older than me. Right?
Yeah, I think what I'm saying is that there's some sort of prompt to do that. If you're, like for me, I'm not the detail person,
I
and
see.
I'm trying to get through everything
Yeah.
I need to get through. So if there's something that stops me that makes me put a date of birth in,
I see.
I won't.
So guides you to have a more robust search right from the start, yeah, and says like, now go, you have the name, but now go ahead and put in the birth
Yep.
date, yeah,
Mhm.
okay, yep, okay, I'm
Okay.
gonna move on.
So we've talked a lot about consent. Let's talk about best practices for utilizing the VITLAccess service. So can you share the optimal times to launch the site and what your experiences are?
Well, for us, we've used it for, like when we get a patient ping, and I don't know if everybody's familiar with patient ping, but anyway, that we get notified that someone's been admitted to a hospital other than the hospital that our providers admit to. We can, usually if we have consent, we can go in and look to see, what's happening and what's going on. And we can follow, like what the progression is and when they're going to be discharged and that sort of thing. So, we can use it that way. We can also use it, like if somebody comes in and says, I went to a specialist at Fletcher Allen and, we don't have the notes. We can ask them to sign a consent right then and there, and then we can just go right in and get the information.
So in the case where you were pinged or you received an alert that your patient had been discharged, a patient in your patient panel has been discharged, then you can understand, if they're on certain medications
Right.
and what they were admitted for initially,
Right.
and then how long they were hospitalized, and then if they're on medications and if there are any, post follow-up instructions or,
Right. And-
safeguards, yeah.
Yeah, and then we can reach out to them, make sure that they have a follow-up with us or whatever
Right,
things
so would
in.
you say, Lauri, then that you're in a better position in terms of, being informed and up to speed on, what you're?
Oh, yeah, absolutely, yeah.
Yep, great.
We probably do things a little differently. Obviously, we are a skilled nursing facility, so we're getting referrals in from hospitals and physicians, primarily hospitals. So I think how we utilize the system the best is, one, when we have an authorization to say somebody wants to come to us, we can access that information and see. We have access to PRISM, which is UVM Medical Center. We have Meditech, and so we can look at all of that, but we can even dive a little deeper into, because all the information is there. Not everything, but you could look a little broader in the VITL system. It also is very helpful for us in regards to medication reconciliation. I'm sure all of you have visited your primary, and everyone always goes through the list of medications, but when you're dealing with the elderly, you're typically dealing with multiple medications. People may be taken off medications in the hospital, different things. So I think this piece is very important as we do the continuity of care in the skilled nursing facility when they come in, making sure that if medications were DC'd, we know why, and if they were on something previously, that we're checking with primaries and things. So I think that's a big piece and key for us to see a whole picture that is helpful.
Yeah, I think I share that. Sometimes people don't know exactly what drugs they're on, and my EMR is able to pull in any prescriptions that have been filled at any drugstore, so that usually gets put in there, but occasionally it doesn't, and so going in, not everybody's records has all of those details, but when they do, it can be very useful, especially in complicated cases. And I also use it after hours when I'm needing to look things up at home. I mean, that's really helpful. I'm not there to get the facts, and I can go on and check, and so a lot of my work is when my kids are asleep.
I'm really glad that you said that, because we hear that a lot in larger organizations where, you have different shifts of people working, and if someone's on the evening shift or someone's, working nights, and they wanted to check for something, that's not happening, during normal business hours to do the typical, phone calling or outreach that you would have to do, in the old world. Hopefully you'll do a lot less of when you're using VITLAccess, but it also gives you that sort of 24/7 access so that you can at least look there to see, if you can get the information that you need, and then hopefully it will be there, and then you save yourself, an outreach the next day. So we're hearing information when a patient's recently been hospitalized and about to be discharged or has just been discharged. We're hearing about off-hours support and also med reconciliation for elderly patients who sometimes aren't good historians, sometimes can't remember what they're taking, what the green pill is, what the purple or the pink pills are. Do you also, Colleen, do you do, I know you're brand new to it, but are you already, or do you envision that a big piece of the usage of VITLAccess for you will be sort of the pre-planning, or the pre-visit planning? It's not really visit in your case, but when a patient is coming back under your umbrella, and you're going to be providing services to them very soon, do you think that you'll be using VITLAccess to help you in the preparation piece of that, to accept them back into your fold?
Yeah, I think so. I think, it has everything all in one area, whereas we do get, obviously, the electronic information from the typically admitting hospitals. I think it would be helpful, too, if somebody has been admitted, then has had an acute situation, gone back to the hospital. We don't always get that document coming back after the hospitalization, so that I think is a piece where the next rollout, currently our users are more administrative users, referral nursing, my MDS coordinator, if she's doing assessments. we're gonna start rolling it out to my lead charge nurses. So after hours, if somebody was coming back from Northwestern Medical Center, say at 7 p.m., and for whatever reason the ED did not transmit some of the information, you know, hopefully that would be an access point that they would have to see, you know, has anything changed. You know, we do have good relationships with the hospitals, and they have gotten better with that information, but I do think there is a piece of that transition that VITL can assist with.
Mm-hmm.
So, and I wanted to speak to the security aspect.
Sure.
As the owner, I was very concerned about this, and I thought, gosh,
Yeah.
you know, you don't want to give somebody, you know, I don't have access to VITL because, you know what,
You
that's
don't need
not
it.
something that is privy in my job.
Right.
I certainly, if I needed to have something done, I have accessible users that can do that. But you worry to say, gosh, would somebody sign on to look at their grandfather's information or somebody's information?
Right.
But I will tell you, VITL assured me through various audits that they do and steps that they do, that I felt comfortable enough to say that I would grant access to sign on for my staff. They're professional staff. They have to do an oath, and they
Mhm.
are audited. So, that liability does weigh heavily on you as you think of the technology world and, people breaking into that and such. But, I think that the world is going this way, and I think it will provide better health care if you have access to information. And, with that audits and the consents and things, I felt secure enough to sign on to that. So.
Okay, great, thank you.
And, just one.
Yeah, sure.
I was gonna say.
Yeah, go right ahead.
I one time was looking a patient up, and I clicked on the wrong patient and didn't realize it until I'd broken the glass.
Mhm.
So I immediately told our security officer that we have, and then we called VITL, and they locked the chart again.
Yeah.
And made a note that,
Yeah.
was a mistake, but they could tell how long I was in there, and, that I was in there, so it's, I think.
Yeah,
it's
I don't know if
pretty-
I don't know if I mentioned that, but
Exactly.
every person, it's not only role-based, but every individual user has their own unique ID and password. And so if I went in, even as a VITL user, but I'm with Colleen, I don't often go into VITLaccess. I don't need to. So I'm probably one of the employees at VITL who's been in there the least. But if I do go in, if I log in, and people with system admin rights, can track what I'm doing, and they can see, if I was doing a training and we were using our test or cert environment, and I was on site with a client, and I was in there to demo usage, like they can see when I logged in, they can see when I logged out, the length of time that I was in there, and what records I accessed and all of that. So it is right down to the individual user level at every organization. So the tracking is very sophisticated.
Thanks for sharing that, Lauri.
I had the same thing.
You had the same thing?
That's why I said the date of birth thing.
Keep going.
Yeah, sure. Yeah, you can.
How much time do we have, Chris? Should we open it up for more questions, or do you want to continue? Does anyone have any questions at this moment to ask the panel?
So, if you have a child gets sick and you're out of the state, how does that go into VITL, or does it?
This is a really good question. Do you want? He's itching to answer this. I could tell.
Not quite yet. Interstate connectivity is something we're working on. First with the network in Albany called Hixney, because they cover much of the western boundary of Vermont. And so they're like in New York, but on the western, boundary of Vermont. But we do have Dartmouth Hitchcock in the network, so we catch some of the New Hampshire stuff. We're just about to implement, I'm crossing my fingers, a connection to the Veterans Administration Hospital, which would give us access to all the VA records across the nation. And so these inter-network connections are challenging in some ways, partly because of technology, but more because of data use agreements and access requirements and such and things like that. For example, we're, as Judith was saying, we're an opt-in state. The action you have to take as a patient is to opt in to get your data to be available. There's many other states that are called opt-out states, meaning you're in, and the action you have to take to not get your records is to opt out. Obviously, those two consents are not necessarily compatible, right? Because I could query your state, but if you're not collecting consent, you can't query mine, you know. So there's things like that that kind of slow things down a little bit, but we actually know how to do the connections and the technology. The other issue we have is that there's about 200 other organizations who do things like we do in the country. And so how do I know which ones to go query, where the record might be? And I was just at a conference a couple weeks ago, and we're starting to think about how to do that too. There are technical ways to tell another network that I have a patient in our network that is from your network. You know, so if I get a Floridian come up here and they get some service because they're skiing or something, and I might be able to tell a service that then allows that other network to know that, oh, they've got records up in Vermont. I got to go query this other network, instead of, say, trying to figure out how to query 199 others, you know, and get back some kind of response, and it's just not practical to do. So we're working on it.
And so what also is the coverage in Vermont of VITL? So how many providers, percentage-wise, are putting data into it?
I had you until you said percentage-wise. and yeah, contributors we know, and I can give you anecdotal evidence. The problem is I don't know the denominator. And by the way, the state doesn't know the denominator. No one knows the denominator, like how many actual medical practices are there and how many docs are practicing in them, and no one knows. It's like, it's surprising. But we have every hospital, including a few that are out of state, like Dartmouth. We have what we believe is the majority of the primary care docs, and we've made it into the specialist realm, not as deep as we want to, but we're working on that. And we continue to expand, you know, home health, and we keep expanding the agencies and others that we're connected to. So compared to many other states, by the way, we're very deeply penetrated. And it's partly because the way VITL started is they started at primary care first because of the Blueprint for Health, and then worked on the hospitals. And that's exactly the opposite of what most other states do. They start with the hospitals and then work on primary care afterwards. And that's just because, as you'd guess, the biggest data contributors are the hospitals typically. And so if you're going for if you try to do volume of data, just having UVM Medical Center accounts for something like 40% of all of it. In the whole, in the whole state, and you had Dartmouth, and there's another, 20% or something, and you've got 60% with two organizations. When you start getting down to the one doc practices, it's, the returns are small compared to the cost of the interface, and so it's more expanding out the market, and we're hoping that things will get easier, so that last mile to those last providers isn't as costly as it is today to do, because it's almost as expensive as to do a 10 doc practice as it is to do a 1, and so where's the benefit to the state and the providers and everyone else? How far do we go before we say that's far enough? I don't know, but we just keep going.
So before we run out of time, so there's a question back here as well. So before we run out of time, I just wanted to, so that was a data contributor question, but you do not have to be a data contributor, meaning you don't, as an organization, it's not a requirement for you to send us your data in order to use VITLAccess. So there are users who are not currently sending data, but VITLAccess service itself, the provider portal, is a web-based, very easy to use service. And so if you're an FQHC right now and you have Part 2 data, and right now until we get the filtering, we're almost there, solution figured out, and you're not contributing, you can still use the VITLAccess service to look up your patients and see their data from other contributors to better treat them. if you're a chiropractor and your prop may not ever contribute your data, that doesn't mean that, you know, as a single chiropractor, you can't use VITLAccess to see everybody else's data so you can better treat your patient. And the other thing before we move to these last questions that I wanted to note was we continue to make inroads in terms of enhanced functionality and automation. We heard about, and I think everyone in this room has heard about, providers being frustrated because, or any clinician, and including physicians, being frustrated that you have too many logins and you have too many passwords to remember, and I don't want to go to 15 different systems. So we are continuing to work very hard on the single sign-on, and I see folks here from UVMMC, and we just completed this project in order to embed a button. Think of a button within your EHR. So with UVMMC, it's Prism/Epic. So there'll be a button within their EHR, and they'll be able to press the button and launch the VITLAccess service from directly within their EHR, so that they don't have to then, you know, go over, fire it up, and do a separate Judith Franz login and password. So we're beginning the onboarding process with UVMMC. We've tested it in the test environment, but we'll be testing it in production, and they will be using it when they go live. And the other automated piece of functionality is, remember how we were talking about opting people in? So we go into the VITLAccess service. We say, Judith gave her consent today. We check her as opted in. It sets a flag. So bear with me now, little techie talk. So that flag now, you can set that within your own EHR. I collected consent from Judith Franz. Now that information is going to travel across the ADT interface, admission, discharge, basically the demographic information interface, and it will be set automatically within the VITLAccess service. So it's a time saver that you won't have to go in and mark it within VITLAccess. It'll just be sent, you know, whenever your demographics are sent across your interface, typically on a daily basis, be pulled from your EHR, sent across the interface, and set in VITLAccess. So that may not be as important if you're a smaller organization, but if you're a larger organization and you're collecting a lot of consent, it's a time saver. So we have, okay, Marianne.
Yeah, hi there. Marianne from the University of Vermont Medical Center. One of the things that you were talking about was interoperability. Because being on Epic, we are able to pull records from outside other Epic organizations. So if you were seen in Montana at an Epic facility, we can pull that information within the system. The other question I had was, you mentioned connectivity to HIXNY. Is that something that is currently in process, or when will that be available? And will HIXNY be able to pull the vital information?
Right, so I'm handing it back to you.
Yep.
This has been a long time.
Yeah, this has been a long time in coming, and we ran into one roadblock with them, and that is that they allow 42 CFR Part 2 substance abuse data into their network and don't require a second consent. And that was something that Vermont didn't feel like they were comfortable with allowing access to. So we had all of this worked out probably more than a year ago about how to do that. And so there's no technical barrier. There's no strict consent barrier other than that. And if so, they can find a way to kind of filter that information, or we can find a way to filter that information. We'd probably have to filter the entire patient, is the only way we can think of doing it. We are just about to, as Judith was saying, implement a way to filter that kind of information out of our network, based on diagnosis and treating provider and a couple other things that some of the organizations have worked with us on. If we can do that, then we think we can probably go ahead and implement the solution with them. So we've got a little bit more planning work to do before we get started on it.
I just have a really quick question. I won't hold everybody up. Mike, this one's for you. I think I heard you say that the community health team members actually have access to VITLAccess. Is that accurate? And then,
At those that are Blueprint community
Right.
health teams, I believe so.
and then
I don't know.
I also thought
You
I
don't think
heard you
they do?
say that,
Okay.
but just for clarification, I also
Oh.
thought I heard you say that you guys would like to be able to give access to other folks, but it was the state that was a limiting factor, and I was just wondering where that might be originating, if that's accurate.
It's actually it's originally originating policy of VITL that the healthcare organizations, remember this was formed out of the hospital association, and so the original contributing providers were mostly the hospitals and other providers. And in order to get this thing started, we had to kind of put some rules about what could happen with the information. And it was originally only for treatment and only for healthcare organizations. It did carve out one term that it called quality review, and it was actually carved out to mean things like the Blueprint for Health. And it allowed that to happen in only two circumstances. One was if the organization said, all of my data can flow to this other thing for quality review. That's how the Blueprint for Health works, is the primary care doc says, all of my data can flow to the doc site clinical registry at the time, for quality review, and that's allowed. Or if you get the patient to sign a special authorization, not the consent form for viewing data, but a special authorization to say, I allow my data to go to my payer or this other organization or a registry or anything, then that is allowed. And those are the only two carve-outs we currently have, other than being a healthcare organization for treating purposes. Now, if the state takes that on as something, they want to do as a law, and that would be great. In other words, we're looking for some kind of help to improve the quality review concept, because it's increasingly important for us to have data spread across organizations that are doing care management and population health and a variety of things. And so right now we're somewhat limited in what we can, in what we can do. But the marketplace has changed from 10 years ago. And so the policies and laws are not quite caught up to that yet.
So I just wanted to ask, how many folks saw John's, or heard, I should say, John's talk this morning when he showed the pie graph with NMC? I think we're excited about it. It's a new report that we're being able to run for our clients. And I thought it was really impactful just to share with folks, because what we're up against sometimes when we're out in the field and we're speaking with organizations is we hear a lot that, I have all the data I need. I have my EHR, I have all the data, quote unquote, all the data on my patient, I'm good, I don't need any more data. So it's tough to sort of educate folks that you don't have all the data, most likely, within your own EHR on any given patient. Or they'll say, well, I have it, and if I don't, I have access to PRISM, so I have all the data I need. And so, yes, if you have access to your own EHR, you have a good amount of data. If you have access to UVMMC's PRISM, that's some more data, right? Probably a lot more. You still most likely don't have all the data. And so it was very, I thought it was an impactful visual representation that in that particular case, when we ran that from the lens of NMC, Northwestern Medical Center, that within their own hospital system, which is Meditech, they had about 25% of the data, and I think I'm remembering this correctly. Their ambulatory practices are on a different system, Medent, and that had, I'm making this part up, 6 or so, Chris might know the exact number, 8, you think it's 8%, from Medent. Interestingly, the folks over in the practices don't often access the Meditech system to see their data within their own organization, and vice versa. And then there are a number of other organizations that had a lot of data on that same population of patients, that same patient universe. So the Notch and Cold Hollow and others. And so it was interesting when I was sharing this with Joel Benware, who's the CIO there. He's like, what am I looking at, Judith? And I said, you have 25% within your hospital system. You have, combined with UVMMCs, it brings you up to 75%. But up in the upper right-hand corner, there's that big 25%, slice up there, which includes your own practices and everybody else. So there's a big chunk of data out there on your patients that you're not currently looking at. You're not viewing it, which may in fact be very helpful, you know, in treatment of your patients. And so it's one system where they could go in and access all that data. Back to it saves time, and you know, there's a lot of pushback from clinicians about I don't want to log into 4 systems. So I just thought I'd bring it home with that one. So we're probably running out of time, but if folks want to stay and ask a couple more questions, we're more than welcome to try to answer them. Sure.
So I'm interested if you have data on frequency distribution of the 2,000 people, how many use it, for how long they use it, and in particular the primary care providers.
So good question. I think I'm understanding. So we actually track metrics on a monthly basis. And we track the number of patient data queries and the total number of users, and come up with a query per user metric. We also now, just recently, I added in a slice or a view of the data by client segment. So the FQHC, you know, segment looks like this. The hospital segment looks like this. You know, independent physicians practices look like that. We track patient consent. We track cumulative queries, patient data queries, queries on average by user. We track consent, pure cumulative number, and percentage rate. I think that's all. There might be a couple that I'm missing, but I can certainly share those with you. But we have a fairly robust reporting system. Yep. Yeah. Yeah. Yep. Good question, though. Are there any other questions? Any other final comments from our panelists? Any words of wisdom that you want to share with anybody? With everybody, I should say. No? Any other questions? No? Okay. Well, thank you all. Thanks for coming to the last session of the day, and thank you again to our panelists.